He has to check the share screen.
Yes, he's checking, sir, that.
Then A1 logics, please don't go on recording now. Go for only live streaming. I think it is working for. Yeah, go so to slideshow mode. Next slide. Thyroids from next slide. Okay, it is working. You can stop. You can stop sharing. We can start.
Sir, can I begin, sir?
Pardon? You stop
Sir,
sharing.
can we start or
Stop.
just some?
No, yeah, no, madam. We will have some 10 minutes. That formal inauguration. Okay, you
Okay,
stop
sir, okay.
sharing.
Okay, sir.
Doctor. Yeah, okay. A1 logics, you can go on recording. A1 logics.
Yes, sir. Good to go.
You go for recording.
Good to go, sir.
I welcome all of you on behalf of ISA Pudukkottai Budan. Our president, Dr. Suresh Kumar, will join a little bit later because of the connectivity problem. Now I request our ISA Pudukkottai secretary, Dr. Periyasamy, to deliver the welcome address.
Thank you, sir. On behalf of ISA Pudukkottai branch, I to all
Dr. Periyasamy, your voice is not audible. Dr. Periyasamy.
Somebody is sharing the screen. Dr. Shilpa is sharing the screen. That is why it's not there.
Sir, you please take over after welcome address.
Welcome, sir.
Sir, I am coming. Sir, yeah, I am audible?
Yes, audible. But Dr. Shilpa madam is trying to share her screen now. Shilpa madam, you can stop sharing.
Sir, okay.
Yeah, it is working. Go for slideshow mode.
I will start again. I will start again.
Once again, let her check.
Yes, sir.
Yes.
Yes, okay. On behalf of this ISA City branch, I welcome you all for this 29th online ISA program. At this juncture, I would like to thank our academic chairman, Dr. A. Minachundram sir, for his continuous effort and making these programs very useful. I welcome Suresh Kumar sir and Treasurer. I welcome our ISA. And I welcome our ISCA city branch members and delegates, those who are attending this 29th program. So from 23rd of March 2022, we conducted so many programs, and now we are entering the 29th program. The topics about thyroid. So for that, I invite Dr. Saya M. Suryavanshi, Professor and HOD, Dr. D.Y. Patil Medical College, Pimpri, Pune. Welcome you, sir, on behalf of ISA Pudukkottai.
Thank you, sir.
And we are having 3 speakers. Dr. Poonam Honurkar, Assistant Professor, Dr. D.Y. Patil Medical College, Pimpri, Pune. Madam is going to talk about anesthetic management of hypothyroidism. Welcome you, madam. And one more speaker, Dr. Shilpa Deshmukh, Assistant Professor, Dr. D.Y. Patil Medical College, Pimpri, Pune. Madam is going to talk about anesthetic management of thyrotoxicosis with the atrial fibrillation for total thyroidectomy. Welcome you, madam.
Thank you, sir.
And our residents, we are having one more residents as a speaker, Dr. Dheeraj Gopal Ravindran, resident, Dr. D.Y. Patel Medical College, Pimpri, Pune. So he is going to talk about thyroid storm.
Thank you,
Welcome,
sir.
sir.
Thank you, sir.
And our ISA, this webinar program is accredited by Medical Council of Tamil Nadu for credit hours. And for that, 100 rupees to be paid to the said account number. You can note it down. And particulars to send to the ISA Pudukkottai at yahoo.com mail ID to proceed further. And today we are having the different topics about thyroid. So small poem about that. Thyroid is a butterfly-like organ sitting on the trachea as dragon. Bring out the catecholamine to beat and treat. Bonded with the steroid for metabolism and produce heat. Make the voice with meaning in correct tuning. Both young and old take heed and listen good. Pulse wave from the pituitary propagate the secretion. Poor secretion of thyroxine prevents the normal function. Graves gives more, but poor Hashimoto's hurdles more. Thyroid alert the brain and activate the heart. It is for doing well and living life in full. With this, I thank you all for opportunity. Over to President Dr. Suresh Kumar, sir.
Thank you, Dr. Periyasamy.
Thank you.
Dear Secretary, my Treasurer, Dr. David, our Academic Chairman, Professor Dr. A.L. Meenakshi Sundaram, sir, our branch members who are assembled here, and our today's program chairperson, Dr. Chaya M. Suryavanshi, Professor and HOD from Dr. D.A.V. Patil Medical College, Pimpri, Pune. And the speakers of today's event, Dr. Poonam Hanurkar, Assistant Professor, Dr. Shilpa Deshmukh, Assistant Professor, and resident Dr. Dheeraj Gopal Ravindran, all from the same Medical College, Pune. Once again, as President of ISA Pudukkottai branch, I welcome you all again for this 29th CME of our branch. We have come a long way, long journey. This is the 29th event. And today's event is very important because we are going to deal with thyroid. Thyroid and anesthesia were inseparable. And most of the times, thyroid is always taken into for granted. And you will miss thyroid diseases in while our pre-operative or pre-anesthetic evaluation. So at this juncture, this topic was put into the CME by our academic chairman. Once again, I thank Dr. A.L.M. sir for giving this nice practical topic for today's CME. I request everybody assembled here to make use of this CME and put it into your practice, whatever the take-home messages you are taking here. For the newcomers and other delegates, please check in with your names, not with your mobile number. And you can also view it in YouTube tomorrow. And you can ask your friends also to view this YouTube link also. And at the end of the session, you put your questions in the chat box so that our chairperson we will have good discussions. Once again, and thank you for the opportunity. I hand over the proceedings to our academic chairman, Dr. A.L.M. sir. Over to Dr. A.L.M. Thank you.
Thank you, President sir. Respected President, Secretary, and members of ISA Pudukkottai, distinguished faculty from D.Y. Patil Medical College today, Dr. Chaya Madam, Dr. Poonam Hannurkar, Dr. Shilpa Deshmukh, and Dr. Dheeraj Kumar Ravindran. Good evening to all of you. Today it is a wonderful occasion that this time the whole team, usually one area will be participating as a faculty and the chairperson will be from the different zone. Today, all four are from D.Y. Patil Medical College. Before I introduce formally the speakers, I want all of you to know about D.Y. Patil Medical College in Pimpri Chinchwad. I went as a MCA inspector there, and if anybody travels to Pune, please see the D.Y. Patil Medical College. It is a really wonderful medical college. The academic area is very, very great for the simple reason they spent nearly 1 crore per year for their library. Nearly 1 crore per year for the library D.Y. Patil Medical College is spending. And when I have seen that anesthesiology department as a MCA inspector, it is full 100% perfect. Rather, I can say it is 200% perfect. The list is heavy. Their turnover is phenomenal. Everything is by the shrewd Chaya Madam. So, Dr. Chaya Suryamsi Madam is the backbone of the anesthesia department of D.Y. Patil Medical College. And when I asked Madam, she has come out immediately with that thyroid chapter, because thyroid is a practical subject. In all the corners of the country, thyroid surgeries are undertaken. And really, the anesthetic problems are phenomenal. And we want the learned people and who have that academic interest. Though Dr. Chaya Madam is a HOD of the anesthesiology department, and she works tirelessly for the improvement and uplift of the department. So naturally, her teammates, Dr. Poonam Hannurkar and Dr. Shilpa Deshmukh are the assistant professors, and they join shoulder to shoulder with her for the upliftment of the medical college. And as usual, we want to introduce the younger faculty as a postgraduate. This time, Dr. Dheeraj Kumar Ravindran has come out. He is entering as a storm, not as a breeze, because he is coming with a thyroid storm. And the thyroid surgeries are practiced everywhere. And it will be a very good treat. Even at the outset, many members have logged in and many are in the YouTube. So without wasting much of the time, I have to hand over the proceedings to Madam. The questions can be placed in the chat box. The discussion will be only at the end of all the three faculty addresses the webinar. And I request everyone to log in by the personal name, not by the device name, because that will be a problem with the MCI certificate attendance wise. So with all these requests, now I hand over the proceedings to Dr. Chaya Madam for the thyroid webinar. Thank you, Madam. Please take over.
Good evening to all, and happy Dasara to everyone and everyone. I'm thankful to Dr. Meenakshi sir and also ISA Pudukkottai City Branch President Dr. R. Suresh Kumar, and also Secretary Dr. M. Periswamy, and all other esteemed members of the branch, for giving us our department opportunity for the this academic participate in this academic webinar. Today's topic is thyroid disease, which is very important topic, practically as well as theoretically very important for all the postgraduate students. So we will, our resident and our faculty will definitely enlighten everyone, mostly all the practical tips regarding the topic. So now I will request our Dheeraj Kumar, the third year resident, to start his presentation on thyroid storm. Over to Dr. Dheeraj.
A very good evening to one and all, and a very happy Vijayadashmi to one and all. First of all, thank you for giving me this opportunity to present on this platform. So myself, I'm Dr. Dheeraj Gopal Ravindran. I'm a third year PG resident from the Department of Anesthesiology from Dr. D.Y. Patil Medical College Hospital and Research Center, Pimpri, Pune. So what is thyroid storm? Thyroid hormone synthesis, pathophysiology, how do you diagnose thyroid storm, precipitating factors, and the management. So these will be the topics that will be covered under this presentation. What is thyroid storm? It is also known as thyrotoxic crisis. It is a life-threatening exacerbation of hyperthyroidism that most commonly develops in undiagnosed or untreated hyperthyroid patients because of stress of surgery or non-thyroid illness. This is characterized by hypothermia or pyrexia, tachycardia, and striking alterations in consciousness. Though rarely seen in this era of medical advancement, it can be fatal, especially in the geriatric population, if the treatment is even slightly delayed. Hence, it is very important to recognize it early and start aggressive treatment to reduce mortality. So coming to the thyroid hormone synthesis, it all starts with the uptake of iodide ion. So the iodine that we take from our diet is converted into iodide ion, and this iodide ion is taken up actively by the follicular cells using a sodium iodide cotransport. And this iodide ion is further taken into the follicular lumen, where it undergoes an oxidation process from an iodide ion to iodine. And this is with the help of an enzyme that is known as thyroxine peroxidase. And this this iodine is what reacts with tyrosine molecules that are present inside the around the thyroglobulin, and it is then converted into monoiodothyronine and diiodothyronine. So once monoiodothyronine and diiodothyronine is formed, it is it then undergoes a process that is known as coupling, where monoiodothyronine couples with a diiodothyronine molecule to form T3, and the diiodothyronine couples with a diiodothyronine molecule to form T4. So coming to pathophysiology, the normal thyroid function is formed by the is because interactions between the hypothalamus, anterior pituitary, and thyroid gland. Thyrotoxicosis is the clinical syndrome that results when the tissues are exposed to high levels of circulating thyroid hormone. Increased T3 will bind to a nuclear receptor, and this will lead to a transcription of specific thyroid hormone response genes, which affects all major organs. In thyrotoxicosis, there is increase in oxygen consumption. It is a hypermetabolic state, and there is increase in sympathetic nervous system activity that occurs. Thyroid storm is an acutely exaggerated manifestation of the thyrotoxic state. The detailed pathophysiology of thyroid storm is not fully understood, but it is thought to be related to increased numbers of beta-1 adrenergic receptors being exposed to increased catecholamine levels, especially in the states of stress. It is also thought that displacement of free thyroid hormones by circulating inhibitors of binding in systemic illness, example cytokines, may also play an important role. So what are the precipitating factors? Superimposed precipitating factors cause thyroid storm in patients with diagnosed or undiagnosed hyperthyroidism. These may be abrupt discontinuation of antithyroid medicine, surgery, which may be thyroid or non-thyroid surgery, trauma, acute illnesses like infections, diabetic ketoacidosis, myocardial infarction, cerebrovascular accident, etc. Parturition, recent use of iodinated contrast medium, burns, etc. The diagnostic criteria. So we have no biological markers to diagnose thyroid storm. We have a scale, an empirical scoring system that is developed by Birch-Wartowski. So it's a Birch-Wartowski point scale that is used for diagnosis of thyroid storm and impending thyroid storm, which is proposed in 1994. This takes into account the following: thermoregulatory dysfunction, tachycardia or atrial fibrillation, disturbances of consciousness, congestive heart failure, gastrohepatic dysfunction, role of precipitating factors. Another criteria that is proposed was by the Japan Thyroid Association thyroid storm diagnostic criteria. So this is the Birch-Wartowski point scale. As I mentioned earlier, these following parameters are taken into consideration, and a scoring system, based on scoring system, if it's less than 25, the storm is unlikely. 25 to 45, it shows an impending storm, and more than 45 shows a thyroid storm. Apart from this, like I said and mentioned earlier, we have a diagnostic criteria that is proposed by the Japan Thyroid Association. The difference is that it requires presence of thyrotoxicosis with elevated levels of FT3 or FT4 as a prerequisite. Even though we have this newer criteria that is proposed by the Japan Association of Thyroid, we still prefer the Birch-Wartowski point scale. So the scoring system is more applicable when the patient is conscious. When a patient is under anesthesia, we can only look for hyperthermia, tachycardia, hypertension, arrhythmias like atrial fibrillation or hypoglycemia. The differential diagnosis of thyroid storm, it is very difficult to differentiate from malignant hyperthermia, pheochromocytoma, and light line of anesthesia. Coming to the management, the treatment strategy of thyroid storm can be broadly divided into 5. Therapy directed against thyroid hormone secretion and synthesis, measures directed against peripheral conversion of thyroid hormone from T4 to T3, reversal of systemic decompensation, treatment of the precipitating illness, and a definitive therapy. So, like I mentioned earlier, there will be hyperthermia. Hyperthermia should be taken care of by surface cooling like tepid sponging, ice pack, decreasing the OT temperature. Also, the administration of cold IV fluids. Also, we can administer paracetamol. Beta blockers like propranolol, IV propranolol, 0.5 to 1 mg IV over 10 minutes, followed by 1 to 3 milligrams IV over 10 to 15 minutes every 4th hourly is the commonly used drug for controlling the tachycardia. If propranolol is not is contraindicated for this patient, then we can go for IV esmolol, which is shorter acting beta blocker. The dose being 0.5 milligram per kg bolus, followed by 50 to 100 microgram per kg per minute infusion. Discontinuation of beta blockers is indicated if the heart rate is less than 80 per minute or the cardiac index is less than 2.2 liter per minute per meter square. If the patient has atrial fibrillation, digitalis 0.125 to 0.25 milligram is indicated. Anti-thyroid drugs like propylthyrouracil is indicated. We give a loading dose of 500 to 1000 milligram and then 250 milligram every 4 to 6 hourly via the nasogastric tube. This blocks the new hormone synthesis and prevents T4 to T3 conversion. If propylthyrouracil is contraindicated, we can go for methimazole, the dose being 60 to 80 milligram per day. And this only blocks new hormone synthesis. It has no role in the peripheral conversion of T4 to T3. Iodine therapy should be started only 1 hour after starting anti-thyroid drugs. This blocks new hormone synthesis and blocks thyroid hormone release. The drugs that are being used may be either potassium iodide or sodium iodide or Lugol's iodine. Apart from this, we can use steroids, as in the thyrotoxic crisis. There will be an relative adrenal insufficiency, and injection hydrocortisone 100 to 200 milligram every 8 hourly, or injection dexamethasone 2 mg IV every 6 hourly is indicated. Supportive therapy being oxygen therapy and ventilation if required. Nasogastric tube insertion, because the propyl thiouracil and methimazole that we have is only available as an oral form. Foley's catheterization. Hydration, nutritional support. Thyroid storm being a hypermetabolic state will require dextrose containing isotonic saline and multivitamins to support the nutrition hydration. Apart from this, if congestive cardiac failure is present, inotropes and diuretics are indicated. Hemodynamic monitoring is also done. Additional measures. A dye like iapanoic acid containing iodine, 1 gram IV every 8 hourly for 24 hours, followed by 500 milligram IV BD can be given if potassium iodide or sodium iodide is not being used. If there is contraindication for iodine or agranulocytosis thionides, lithium carbonate 800 to 1200 milligram per day can be given. For refractory cases, acetylate, hemodialysis, and plasmapheresis has been indicated. Also, we should keep in mind, even though we're treating thyroid storm, we should always treat the precipitating illness. There should be an active search and treatment for infection and other likely precipitants such as trauma, myocardial infarction, diabetic ketoacidosis, etc. Thank you.
Thank you, Dheeraj. Now I will request Dr. Shilpa Deshmukh to start her presentation. She will be presenting a patient with the thyrotoxicosis with the atrial fibrillation for thyroidectomy. Over to Shilpa.
Thank you, ma'am. Good evening, everyone. Am I audible?
Yes, Shilpa.
Yes, ma'am. Okay, and I've shared my screen. Is it visible?
Yeah, we can see your screens also.
Okay, ma'am. Good evening, everyone. I'm Dr. Shilpa Deshmukh, Assistant Professor in Department of Anesthesiology at Dr. D.Y. Patil Medical College, Pimpri, Pune. I thank ISA Pudukkottai City Branch for giving me this opportunity to speak on my today's topic of anesthetic management of thyrotoxicosis with atrial fibrillation posted for total thyroidectomy. A brief overview of what will be covered in this topic. It's what is thyrotoxicosis, its etiology, types, clinical features, diagnosis and treatment, and anesthetic considerations regarding atrial fibrillation in thyrotoxicosis with atrial fibrillation for total thyroidectomy. So thyrotoxicosis is frequently confused with hyperthyroidism. And therefore, we need to know what is hyperthyroidism and what is thyrotoxicosis. Hyperthyroidism is defined as an increase in thyroid hormone levels due to increased thyroid gland secretion or synthesis. Whereas thyrotoxicosis is a hypermetabolic clinical syndrome that is a group of signs and symptoms induced by thyroid's improper activity in the tissue. The cause of thyrotoxicosis is a multitude of disorders that cause an excess of thyroid hormones in the tissues or in the thyroid gland. The etiology is based on the etiology can be divided into primary, secondary, and iatrogenic. The primary thyrotoxicosis is when the pathology is within the gland. Secondary is when the thyroid gland is stimulated by excessive thyroid stimulating hormones in the circulation. So the primary thyrotoxicosis, the main cause, the 90% cause is Graves' disease. Other causes can be toxic multinodular goiter, toxic adenoma, and carcinoma and others. The secondary thyrotoxicosis causes can be pituitary adenoma, secreting TSH, trophoblastic tumors, choriocarcinomas, and other causes mentioned in the slide. And iatrogenic causes like thyroid replacement therapy, iodine therapy, which is also called as Jod-Besdor's phenomena, amiodarone, and other factors like lithium and interleukin-2 alpha. The primary and secondary thyrotoxicosis features can be characterized with regards to the appearance of swelling. Appearance of swelling and toxic symptoms is simultaneous in primary thyrotoxicosis, and that in secondary, the swelling appears first and the symptoms follow. The swelling in the primary thyrotoxicosis is diffuse and it's nodular in secondary. The symptoms appear suddenly and are severe in the primary thyrotoxicosis, and they are gradual and mild in secondary. The CNS manifestations are the main manifestations. They are the dominating ones in the primary thyrotoxicosis, and the CVS manifestations dominate in secondary. Exophthalmos and other eye signs are common in mostly in primary thyrotoxicosis, and they are said to be rare in the secondary thyrotoxicosis. So these are the clinical features according to the organ systems. In the generalized symptoms are weight loss, increased appetite. That could be due to the increased basal metabolic rate and protein catabolism, insomnia, restlessness, fatigue. In GI symptoms, diarrhea, dehydration can be seen. In CNS symptoms, nervousness, hyperexcitability. Dermatological symptoms, there is intolerance to heat, excessive sweating. CVS systems manifest with tachycardia, cardiac dysarrhythmias, mitral valve prolapse, or heart failure. There can be weakness of large muscle groups, osteoporosis. Menstrual abnormalities can be seen in women, most common being amenorrhea, and ophthalmologic signs, which we will be discussing further. And respiratory distress can also be seen. Going on to central nervous system, there is hyperactivity, nervousness, and irritability seen in these patients. This can lead to easy fatigability. Insomnia and impaired concentration is very common. Fine tremors can also be seen. Hyperreflexia, muscle wasting, proximal myopathy without fasciculations can also be seen in these patients with hypokalamic periodic paralysis. In CVS, there is tachycardia, there is increase in sleeping heart rate. Dysarrhythmias, usually supraventricular dysarrhythmias, and atrial fibrillation are seen. Cardiac failure, angina can also be manifested. There is increase in cardiac output due to increased heart rate and increase in stroke volume. There is a difference in increased pulse pressure difference. Pulmonary hypertension, it is more commonly seen in females than in males, which responds to treatment to thyrotoxicosis. There is hyperdynamic circulation due to increased blood volume, which is seen as bounding pulse in examination. The effects of cardiovascular system are due to elevated thyroid hormones, which alter the receptors in the heart, specifically the beta-1 adrenergic and mu2 receptors. They cause increase in the sympathetic function, increased heart rate, and decreased atrial refractory period. Due to the shorter action potential in the refractory period of repolarization, there is an ectopic activity from the left atrium to the whole atrium, which leads to atrial fibrillation. Thyrotoxicosis can be the sole cause of atrial fibrillation and may predispose to atrial fibrillation related complications. The eye signs and symptoms which need to be known by all the postgraduate students especially, they are lid retraction, von Graff's sign, Stellwach's sign, Joffre's sign, Dalrymple's sign, Mobius sign, and Rosenbach's. Also, there is Graves' ophthalmopathy, which is also called as thyroid-associated ophthalmopathy due to stimulation of overexpressed TSH receptors in the retroorbital tissues. The earliest manifestation of this can be just a sensation of grittiness or eye discomfort, excessive tearing. Proptosis can be seen in 1/3 of these patients. Periorbital edema and chemosis is also common. Diplopia will be seen if there is severe muscle swelling. The most serious manifestation of this ophthalmopathy is due to compression of the optic nerve at the apex of orbit, causing a papilledema, peripheral field defects, and if untreated, can lead to permanent loss of vision. Skin and nail manifestations are also present. They are like warm and moist skin. Sweating and heat intolerance are present in these patients. Palmar erythema, onycholysis, pruritus, urticaria, and diffuse hyperpigmentation is also present. The hair texture of these patients, it's fine. There's diffuse alopecia, which can be seen up to 40% of patients. Thyroid dermopathy is seen less frequently, and thyroid acropathy, which is a form of clubbing, it is found in less than 1% of patients with Graves' disease. In GI system, there is increased stool frequency, diarrhea, steatorrhea, weight loss in spite of increased appetite. In reproductive system, as mentioned earlier, amenorrhea in females. In pregnancy, it can lead to low birth weight babies or preeclampsia, and in men, it can cause impaired sexual functions and rarely gynecomastia. In the skeletal system, osteopenia can be seen, hypercalcemia and hypercalciuria can also be seen, along with increase in fracture rate. And as we know, the thyroid gland, it usually diffusely enlarges to 2 to 3 times its normal size with firm consistency. And thrill or bruit, if noted, it is due to the increased vascularity of the gland. Diagnosis of thyrotoxicosis is usually laboratory based with thyroid function test, TSH assay, free T4, T3 resin uptake, and free T4 index. It can be also be diagnosed with radioactive iodine uptake, TRH stimulation test. This is to test the pituitary function. And in imaging, ultrasonography, FNAC, thyroid scan, CT scan, and venography. In ultrasonography, it can be used to differentiate between the cystic, mixed, and solid lesions in the gland. Thyroid scan can evaluate the nodules as warm. That means if the scan result is warm, it is normal. If it's hot, it's hyperfunctioning. And if it's cold, it's hypofunctioning. So coming to the treatment of thyrotoxicosis, it is mainstay is antithyroid drugs, beta adrenergic blockers, radioactive iodine, and surgery. So in antithyroid drugs, the methimazole and carbimazole, these are the thienamides, which inhibit the thyroperoxidase, which decreases the uptake and concentration of inorganic iodine in the thyroid gland. Methimazole in the dose of 5 to 40 mg a day dose can be taken, and carbimazole 10 mg to 70 mg once a day dose. Propylthiouracil, in addition to inhibiting thyroperoxidase, can inhibit peripheral conversion of T4 to T3, and it's taken in the dose of 100 mg to 800 mg daily in divided doses. Beta blockers. Before the antithyroid drugs take effect, beta blockers are used to control palpitations and tremors. They relieve the signs and symptoms, but they do not reduce the thyrotoxicosis disease per se. Non-selective beta blockers are preferable as also block peripheral conversion of T4 to T3 via beta action over 1 to 2 weeks. The most commonly used beta blocker is propranolol in the dose of 10 to 40 mg 3 to 4 times a day. As it's a non-selective beta blocker, it also helps in conversion of T4 to T3. Other drugs like atenolol, nadolol, metoprolol, and esmolol can also be used. Esmolol, especially as Dr. Dheeraj has mentioned, in case of thyroid storm, as it can be administered IV also. Iodides, saturated solution of potassium iodide, SSKI. Antithyroid drugs should precede SSKI because as if iodides are given alone, it will act as a substrate for the new thyroid hormone synthesis and can worsen thyrotoxicosis. It's given in the dose of 3 drops orally 8 hourly for 7 to 14 days. There is no beneficial effect seen if these are given beyond 14 days. And to reduce the gland vascularity and hormone release if the iodides are given, that effect is called as Wolff-Chekhov effect. Lugol's solution can also be given alternatively in iodides, 5 drops 3 times a day. They inhibit the release and decrease the synthesis and block the peripheral conversion of T4 to T3. The iodide therapy can be added 1 week before surgery and continued throughout the day till the day of the surgery. Radioiodine therapy is given in patients with primary thyrotoxicosis for more than 40 years of age, autonomous toxic nodules, and recurrent thyrotoxicosis. They destroy the thyroid cell function, and we need to stop antithyroid drugs at least 3 days prior before starting of radioiodine therapy. This can cause hypothyroidism also, and it's not recommended in pregnancy due to risk of fetal hypothyroidism. Surgical treatment is for severe hypothyroidism, pregnant women who cannot tolerate antithyroid drugs, large goiters with severe ophthalmopathy or pressure symptoms, solitary toxic adenoma, failed medical therapy, and underlying carcinoma. So coming on to the anesthetic considerations for a patient of thyrotoxicosis with atrial fibrillation posted for total thyroidectomy. In pre-op evaluation, history taking is very important. If there's a sudden onset, there is a rapid rate of growth of the swelling, it can point towards malignancy. If it's a long-standing duration swelling, we should be suspecting tracheomalacia in such patients. Dyspnea, dysphagia, hoarseness, these can give us idea about pressure effects of the swelling over trachea, esophagus, and recurrent laryngeal nerve respectively. History of palpitation is seen in patients who present with atrial fibrillation, precaudal pain or exhaustion in patients of heart failure, and increase in diet, decrease in weight, menstrual irregularities, nervousness, sleep disturbances. These all can be elicited in the personal history. In general physical examination, the patient will give history of loss of weight, and that should, and decrease in BMI can be calculated. There is less BMI, low BMI seen in these patients. Pulse rate, the rate and regularity, if it's irregularly irregular, it points towards atrial fibrillation, and bounding pulse can be seen in patients due to hyperdynamic circulation. In neck, there is fullness due to the swelling. The patient's temperature, sleeping pulse rate, blood pressure, all will be increased. And in skin, it will be moist palms, and the patient can also have fine tremors, and the overall demeanor of the patient will be anxious and nervous. Airway assessment can be done for these patients as according to our standard protocols, but in these patients, usually mouth opening and Mallampati criteria grading is normal. Usually the distances, the thyromental distance, the sternomental distance, they are not accessible due to the presence of swelling. And again, due to the swelling, the neck movements can be restricted. In local examination of thyroid, Pizzolo's method is done for obese and short-necked patients to make the swelling more prominent. The examiner stands in front of the patient. The patient is asked to place his hands behind the head and push head backwards towards the clasped hands and swallow. So the thyroid swelling is seen as moving during the deglutition. Pemberton's sign is looked for to rule out retrosternal extension. In this, the patient is asked to raise both his arms up over his head until they touch the ears, and this is maintained for a while. If congestion of face and distress is seen in the patient, it is due to the obstruction of great veins at the thoracic inlet due to the retrosternal extension of the gland. On palpation, Lahey's method is done for palpation of the posterior surface of the gland. In this, the examiner stands in front of the patient, and if the left lobe is to be palpated, the gland is pushed to the left from the right side to make the left lobe more prominent, and then the posterior surface is palpated with the other hand. The opposite maneuver is to be done if we want to palpate the right side. Kreil's method is done for a small or a slight enlargement of thyroid gland or in the presence of nodules, in which it can be appreciated just by placing a thumb over the swelling when the patient swallows. Cocker's test is done to rule out if is there a compression on trachea. It is done by giving a slight pressure on the lateral lobes of thyroid. If it causes stridor in the patient, the test is said to be positive, telling us that there is a compression in trachea. From anesthesia point of view, this tells us that we will have to consider a smaller size of ET tube, and while passing the ET tube, it should be placed beyond the narrowing. Berry's sign is seen in when the malignant thyroid gland engulfs the carotid sheath completely. So there is, we cannot palpate the carotid pulsations. On percussion over manubrium sterni, if there's a dull note, we will have to consider the retrosternal goiter extension. And on auscultation, if a brew is seen over the swelling, it indicates increased vascularity. Toxic manifestations examination, exophthalmos as described earlier. Tachycardia in this resting pulse rate, if it's between 80 to 90, it's mild thyrotoxicosis. 90 to 110, it's moderate thyrotoxicosis, and more than 110, it's said to be severe thyrotoxicosis. Tremors can be seen on stretched hands, protruded tongue, or fingers in primary thyrotoxicosis. In CVS examination, signs of CCF can be elicited, and systolic murmurs can be heard if due to hyperdynamic circulation. In central nervous system, myopathy and tremors can be seen, and hyperreflexia can be elicited. Coming on to investigations, a complete hemogram needs to be done because these patients can have anemia, thrombocytopenia, and agranulocytosis. Coagulation profile, especially INR, has to be done because as this patient is having atrial fibrillation, can be on anticoagulant therapy. These patients can have hyperglycemia. So random blood sugar levels need to be done along with obviously thyroid function test. ECG to rule out tachycardia, ST elevations, or atrial fibrillation. A 2D echo can be done to see if there is left atrium enlargement, to see ejection fractions, any LA clots, or left ventricular hypertrophy. Or a transesophageal echocardiography could also be done to rule out the LA clots. Indirect laryngoscopy needs to be done to note down the movement of vocal cords to see the difference between the pre and post surgical status of the vocal cords. This is how an ECG of atrial fibrillation will look like. Atrial fibrillation, in atrial fibrillation, there is absence of P waves, and the RR interval is irregular. That is, it's irregularly irregular. Radiological investigations, which can be done for airway assessment also, includes chest X-ray, X-renic, AP lateral, to view the position of trachea, deviation, or any pressure effects. And CT scan is more specific for the same. And CT scan can especially tell us the AP diameter of trachea, which will help us in estimating the ETD size to be used for the patient. If anticipated difficult airway is expected, then pulmonary function test, flow volume loops, and flexible bronchoscopy for better visualization of glottic opening can also be done. So the main goal of our preoperative assessment should be a youth thyroid patient. For this, the treatment of thyrotoxicosis to be done. Antithyroid drugs take about 6 to 8 weeks to make the patient pharmacologically euthyroid. SSKI may also be used and along with beta blocker therapy. As this patient is having atrial fibrillation also, the rate control in atrial fibrillation is to be done mainly by beta blockers. Then there's rhythm control and anticoagulation, as there is risk of thromboembolism in AF patients. The mainstay of treatment in patients with atrial fibrillation and thyrotoxicosis is restoration of euthyroid status, as most of the patients after achieving euthyroid status revert to normal sinus rhythm. If it still persists, then we can go to the rhythm control, which can be done by pharmacological cardioversion after achieving euthyroid states and 3 weeks of oral anticoagulation. For rate control, the drugs that are used mainly beta blockers. The other drugs which are used are calcium channel blockers, amiodarone, and digoxin. The metoprolol dose is around 2.5 to 5 mg IV if given IV, and 25 to 100 mg BD. If contraindicated, like in asthma patients, then calcium channel blockers can be used. And digoxin especially can be used if the patient is unstable, but dose adaptation needs to be done for renal disease patients. For pharmacological cardioversion, anti-arrhythmic drugs of class 1C and 3 are used, like flecainide, propafenone, amiodarone, and ibilutide. Now, preoperatively, if the patient of atrial fibrillation is on anticoagulants, so warfarin, if the patient is on, it has to be discontinued 5 days before the surgeries and 3 days before subacute low molecular weight heparin or unfractionated heparin need to be started. And INR is to be assessed a day or two prior. And if it's still more than 1.5, vitamin K can be given. The low molecular weight has to be discontinued 24 hours before surgery, and unfractionated heparin 4 to 6 hours before surgery. The direct anticoagulants like rivaroxaban, apixaban, and dabigatran need to be suspended 48 hours before surgery if the creatinine clearance is more than 50 ml per minute, and 4 days before surgery if creatinine clearance is less than 50 ml per minute. To assess if the patient has achieved euthyroid status, thyroid function tests need to be done every 4 weeks. The euthyroid status clinically assessed by heart rate less than 90 beats per minute in normal sinus rhythm, normal pulse pressure, resolution of new cardiac relief of tremors and anxiety palpitations, fetal diagrams. So the plan of anesthesia is usually general anesthesia, especially as our patient is with atrial fibrillation. So the goals in general anesthesia, which need to be looked at to achieve adequate depth of anesthesia, to inhibit the sympathetic sympathetic response to surgical stimuli. Aim is to suppress the sympathetic activity by avoiding atropine, drugs like atropine, scopolamine, ketamine, pancuronium, ephedrine, and epinephrine, as they cause tachycardia, and certain they interfere with heat regulation. If there is anticipated difficult airway, the difficult airway cart, airway preparation, and OT preparation needs to be done. Rice tube insertion in case of thyroid storm, as mentioned earlier, for giving the drugs for thyroid storm through Rice tube. Adequate eye protection also needs to be taken care of, as these patients have exophthalmos and other eye signs. Pre-medication, prior to that, NPO guidelines need to be followed, informed consent, as it's a high-risk procedure. Consents for ICU, post-op ventilatory support need to be taken, and invasive monitoring procedure consents need to be taken. After a wide-bore IV access, pre-op sedation can be done with mild sedation with benzodiazepines, and glycopyrrolate can be used as anti-siloglog. Antithyroids and beta blockers need to be continued till the day of surgeries. And post-op nausea, vomiting, and antibiotic prophylaxis can be given. And monitoring pulse ox, NIBP, IBP, ECG, temperature and ETCO2, especially for intra-op thyroid storm, where these can rise tremendously in these patients. Neuromuscular monitoring, especially as there is increased incidence of myasthenia gravis in thyrotoxicosis patients. BIS monitoring to monitor the depth of anesthesia. To attenuate the sympathetic response, IV lignocaine, esmolol infusion, and dexmedetomidine can be used. After pre-oxygenation, if there is no anticipated difficult airway, then thiopenton can be used for induction. It is a drug of choice as thioureline nucleus inhibits peripheral conversion of T4 to T3. And if there is anticipated difficult airway, then again, airway preparation is very important to attenuate the sympathetic response in awake fiber optic intubation. And video assisted laryngoscopy can also be done. And choline, if the airway is not difficult, if the airway is difficult, and Becurium can be given if the airway is easy. The tip of ET tube should be taken care that it is advanced beyond the area of tracheal compression. Use of armored flexometallic tube is to be used to avoid kinking, and tube should be firmly taped in position and all connections secured, as access during the surgery is very limited. Careful titration of muscle relaxants is to be done with neuromuscular monitoring. The patient positioning for the thyroid surgeries, the neck is fully extended and tilted. Head tilt is up to 15 to 20 degrees to reduce the venous bleeding. And but we have to take care that there is no hyperextension by giving a sandbag beneath the shoulders and a horseshoe-shaped ring beneath the head. Neck extension can change the ET tube position. So rechecking of tube position after final positioning of the patient needs to be done. Arms are secured by the side. So ulnar nerve paddings and extension tubings for IV access need to be done. As there is limited access to the airway, long hoses of our respiratory or breathing circuits needs to be taken care of. And special care needs to be done to protect the eyes from injury as they are prone to corneal abrasions because of exophthalmos and eyelid retraction. These patients can have profound hypotension at the time of induction or intraoperatively too. And if any hypertension occurs, it's to be treated with fluids and vasopressors. Phenylephrine and norepinephrine are to be used, and sympathomimetic drugs like ephedrine can cause exaggerated response, so they are to be avoided. Avoid hyperventilation as the resultant alkalosis and hypokalemia can aggravate muscle weakness in this patient, and excess airway pressure can occur during manipulation of trachea during the surgery. Head down tilt and Valsalva maneuver has to be done before wound closure to help identify bleeding points. Reversal and extubation, the care needs to be taken. That a full reversal with neostigmine and glycopyrrolate is to be done after a TOF ratio on our neuromuscular monitoring comes to more than 0.9. Visualization of vocal cord movement to check the recurrent laryngeal nerve function can be difficult due to sympathetic stimulation of a patient who has already recovered from the neuromuscular function. In cases of suspected tracheomalacia in a large thyroid gland, a cuff leak test needs to be done, or fiber optic bronchoscope to assess the airway collapse when the ET tube is being pulled back. If there is a tracheal collapse, the ET tube needs to be advanced immediately and to protect the airway, and mechanical ventilation is to be continued post-operatively. For extubation, deep cleans are preferred to avoid cuffing, and wound hematoma is avoided, which can cause airway obstruction post-operatively. In post-op analgesia, wound infiltration with acetaminophen, NSAIDs can be given. Superficial cervical plexus block, USG guided is preferred as this patient could already be on anticoagulant cover. So USG guided will cause less complications. Postoperatively, we have to take care that the removal of thyrotoxic gland does not mean immediate resolution of thyrotoxicosis. The T-half of T4 is about 7 to 8 days. Therefore, beta blocker therapy needs to be continued in a post-op period. Antithyroid drug therapy can be discontinued. Calcium supplementation can be given in case a parathyroid gland is accidentally removed, and calcium levels need to be checked 6 to 24 hours post-surgery. If the patient was already on bridging therapy, so low molecular weight heparin or unfractionated heparin should be started 48 to 72 hours after surgery. But risk of bleeding always needs to be assessed before starting off these drugs. Warfarin resumption, depending upon the hemostasis and after discussion with the surgeon, needs to be done. And if direct oral anticoagulants are to be resumed after 48 to 72 hours of surgery. Complications which can be seen in these patients intraoperatively are atrial fibrillation. The mainstay of treatment for atrial fibrillation is beta blockers. As mentioned earlier in the treatment, the drugs which can be given IV can be given propranolol and metoprolol. Carotid sinus stimulation can occur during surgery by surgeon stimulation of carotid sinus, which can cause bradycardia and hypotension. So the surgeon needs to stop the stimulation. We have to tell the surgeon, and to prevent recurrence, lignocaine can be sprayed over the carotid sinus. Tachycardia can be treated with beta blockers. Thyroid crisis, as mentioned earlier, needs to be handled, as mentioned earlier by Dr. Dheeraj. There is chances of hemorrhage intraoperatively and postoperatively, and damage to nerves. The complications in post-op, immediate post-op are thyroid storm, hematoma, tracheomalacia, nerve palsies, laryngeal edema, and hypoparathyroidism. And late complications are hypoparathyroidism, hypothyroidism, or hypocalcemia. Regional anesthesia and local blocks. These are, first of all, that patients needs to be cooperative if these method of anesthesia are to be preferred. It is beneficial if the patient is medically compromised as in thyrotoxic patient, and it avoids risk of general anesthesia, and intraoperative voice monitoring can be done, and it's a very good post-op analgesia. Contraindications for regional blocks are planned sternotomy, retrosternal extension, need for extension, neck extension, chronic cough, and if the patient is unable to lie still with neck extended. And we have to take into consideration complications of cervical epidural, like bradycardia, hypertension, and cervical plexus block, phrenic nerve palsy, vertebral artery, and subdural injection. So summarizing, for the patients of thyrotoxicosis with atrial fibrillation, these should be clinically and chemically, the patient should be clinically and chemically euthyroid and in normal sinus rhythm prior to elective thyroid surgery. Sympathetic activity suppression is crucial, and it is this gives a better intra-op hemodynamics for us. Perioperative complications and knowledge of that is important, and thorough pre-op preparation and intense monitoring can be done accordingly. Difficult airway, expected or unexpected, should be anticipated. Communication between surgeon and anesthetist is vital for comprehensive and safe intra-op management. A post-operative assessment is important to ensure that the patient's airway remains patent and hemodynamic stability is maintained. Thank you.
Thank you, Shilpa. Very informative and practical tips are given in your presentation. Hope it will help all your postgraduate students for managing the patient with the thyrotoxicosis with atrial fibrillation. Now I will request our next speaker, Dr. Poonam Hannurkar. She will be talking about anesthetic management of the patient with the hypothyroidism. Over to Dr. Shilpa, can you stop sharing?
Yes, ma'am.
Dr. Poonam is just trying to share the screen for a minute. She's trying to share the screen. Just a minute. Over to Dr. Poonam.
Hello. Hello, am I audible?
Yes.
Hello.
Uh,
Ma'am, have you connected in two devices? Please mute one of the device.
Hello.
Yes, ma'am, now it is clear.
Good evening, everyone. Am I audible now?
Yes, yes.
Yes, ma'am.
Myself, Dr. Poonam Hanurkar. I am assistant professor in Dr. D.Y. Patil Medical College, Pimpli. I would like to thank ISA Pudukkottai for giving me this wonderful opportunity. Today, I'm here to present on the topic anesthetic management of hypothyroidism. So let me begin with a hypothetical case. So wherein a 45-year-old female comes to you, which is posted for thyroidectomy with chief complaints of chronic fatigue, cold intolerance, increasing over a period of 4 months. She reports 5 kg weight gain in the last 3 months, despite having a decreased appetite. She also gives a history of more sleepiness lately. On examination, she manifests dry skin and hair loss, which is a change from her usual. Laboratory results for the patient are as follows. Kindly note the values of TSH, free T4 and free T3 values. Now the questions that come into our mind are, what will be your approach for the above case? How can the diagnosis best be confirmed? What is the most likely cause of this patient's disease? And how should this patient be managed? Hopefully by the end of my presentation, all the residents present over here would be confidently able to answer all these questions. So let me go in short about the synthesis of thyroid hormones. I won't be telling in detail as this has been discussed by Dr. Dheeraj already. I'll just enumerate the 6 stages. First is thyroglobulin synthesis. Then comes the iodide trapping. Then there is oxidation of iodide ions, followed by the transport of the iodine into the follicular cavity of thyroid follicles. Then there is iodination of tyrosine amino acids, followed by organification or coupling reactions between monoiodotyrosines and diiodotyrosine, leading to formation of T3 and T4 thyroid hormones. So basically, thyroid gland releases 100 to 125 micrograms of thyroxine T4 daily and small amount of T3. Triiodothyronine is only 10% generated from the gland. 90% is formed by the conversion of T4 to T3. 99.5% is present in the bound form, whereas tetraiodothyronine is exclusively generated from the gland, half-life of which is 7 days. 99.9% is bound to thyroid binding globulins, transthyretin, and albumin. Potency ratio of T3 is to T4 is that of 4:1. Now, this is the thyroid hormone table enumerating the normal ranges. In hypothyroidism, the most important one is TSH, normal range for which is 0.5 to 4.5 milli-international units per liter. How does the regulation of these hormones occur? So let us start with the hypothalamus. It releases TRH, which acts on the anterior pituitary and leads to generation of TSH. This TSH then goes and acts on the thyroid gland, leading to formation of thyroid hormones T3 and T4. Then they act on the target cells throughout the body. There is a negative feedback mechanism by these thyroid hormones both on TSH and TRH. Decrease in TSH will cause decreased production of T3 and T4, and hence there will be decreased size and vascularity of the gland and vice versa. In addition to this negative feedback mechanism, there is an autoregulatory mechanism also for maintenance of the thyroid stores. Now, to explain the etiology of hypothyroidism, let's go into detail of this picture. Primary hypothyroidism is caused because of the diseases of the thyroid gland itself. Secondary hypothyroidism is caused by pituitary disorder, while tertiary hypothyroidism is caused by hypothalamic diseases. Enumerating important causes of these, in primary hypothyroidism, there is decreased level of T3, T4 despite having adequate TSH levels or raised TSH levels. Causes are iodine deficiency, such as in endemic goiter, autoimmune thyroiditis, which is the most common cause of primary hypothyroidism, and it is Hashimoto's thyroiditis, previous radioiodine treatment, previous thyroidectomy surgery, external beam radiotherapy to neck, medication intake such as that of lithium or amiodarone, food goitrogens in diet like broccoli, cauliflower, radishes, turnips, and cabbage can also cause primary hypothyroidism. Now, what is endemic goiter? It is basically iodine deficiency goiter, which is a significant environmental problem. Iodine is essential for thyroid hormone synthesis as it is not synthesized by the body. Leaching of the iodine from the soil due to erosion by heavy rains or deforestations like in hilly areas such as Himalayas leads to goiter due to dietary deficiency of iodine in the soil. Hence, no T3, T4 production is there, so there is excessive TSH stimulation. This in turn leads to increased production of thyroglobulin, which presents as large goitrous swelling in most commonly in females, as can be seen in the figure. Now, what is secondary hypothyroidism? In this, there is reduced levels of T3, T4, and TSH hormones, and causes are lesions compressing the pituitary gland, such as pharyngioma, adenoma, meningioma, glioma, surgery or radiation to the pituitary gland, pituitary apoplexy, Sheehan's syndrome, infiltrative disorders such as sarcoidosis, amyloidosis, infections such as tuberculosis and syphilis. Tertiary hypothyroidism is caused by reduced TRH levels, and it is caused by lesions of hypothalamus. Now, another form of classification is that into congenital and acquired hypothyroidism. Congenital causes are thyroid dysgenesis, thyroid dysharmonogenesis, and most importantly, let me go into the topic of cretinism. Cretinism is basically a condition in which the infant or child has thyroid hormone deficiency from birth itself. There is extreme hypothyroidism during fetal life, infancy, or childhood. Types can be congenital, which is because of the absence of the gland itself at birth, or there can be failure of the gland to produce the hormones due to a genetic defect. For example, Pendred syndrome, in which the protein pendrin is lacking. Endemic cretinism is because of iodine lack in maternal diet during pregnancy. Manifestations of cretinism are impaired mental growth, short stature, ossification of bone is delayed, persistence of physiological jaundice, hoarse cry, constipation, somnolence, feeding difficulties, tooth development may be poor, there may be broad and puffy face with wide set eyes, depressed nasal bridge with protruding tongue and enlarged lips are seen, skin may be thick and rough, infant appears dull and apathetic. Sometimes umbilical hernia may be associated. So for the treatment of cretinism, thyroid hormone replacement immediately within few weeks is very important, as it prevents both mental and growth retardation. L-thyroxine is the drug of choice, dose of which is 10 milligram per kg per day in infancy. Introduction of iodine-rich diet when it is age appropriate should be started. Now let's go into adult hypothyroidism. So signs and symptoms of hypothyroidism, as is visible from the figure, it involves almost all the organs of the body. Going into the details of which, generally there is tiredness, somnolence, weight gain despite poor appetite, cold intolerance, hoarseness or husky voice, and goitrous swelling can be present. In neuromuscular system, there is depression or psychosis, muscular stiffness is present with aches, delayed relaxation of tendon reflexes is seen, carpal tunnel syndrome because of the flexor retinaculum thickening, tingling and numbness may be present in the median nerve innervation area. In ears, there may be decreased auditory acuity with deafness. Dermatologically, dry flaky skin is characteristic with alopecia, itching in the skin, and thick doughy induration of the skin because of the depositions of glycosaminoglycans, and this leads to non-pitting edema. Now in the cardiovascular system, profound bradycardia is seen in severe hypothyroidism. Pericardial effusion may be present because of the accumulation of cholesterol-rich pericardial fluid. Impaired baroreceptor reflexes are present. Decreased cardiac output with increased systemic vascular resistance is there. And overall, a low intravascular volume is present, which leads to hypotension in these patients. Hypothyroid cardiomyopathy is characterized by systolic and diastolic dysfunction. In ECG, you may find inverted T waves, low amplitude P waves, and QRS complexes. Muffled heart sounds are usually audible. In respiratory system, maximum breathing capacity is decreased, diffusion capacity is decreased, ventilatory response to hypercarbia and hypoxia is impaired, dyspnea may be seen due to pleural effusion. In gastrointestinal system, constipation, ascites, paralytic ileus may be seen. In renal system, urinary retention is present, and there is increase of ADH hormone. This leads to decreased free water clearance, which in turn leads to dilutional hyponatremia. Anemia is present, cause of which may be iron deficiency if there is menorrhagia present, or in autoimmune disorders such as Hashimoto's thyroiditis, pernicious anemia may be associated. In reproductive system, in chronic hypothyroid patients, it is usually associated with hypogonadism, which can present in females as infertility or menorrhagia. Breast engorgement, galactorrhea is seen. In males, impotence and loss of libido is seen. In skin, cold clammy extremities because of peripheral vasoconstriction is seen as response to hypothermia, and rough and doughy skin texture is visible. In face, dull expressionless faces, which is known as mask-like faces, is seen. Sparse hair are present. Periorbital puffiness, which is known as bagginess under the eye, is visible, and macroglossia is seen. This is a picture showing characteristic dull lethargic look of a hypothyroid patient with mask-like faces. Now, what is sick euthyroid syndrome? Basically, there is abnormal thyroid function test that occurs in the setting of acute illness in critically ill patients. There is non-thyroidal illness without any pre-existing hypothalamic, pituitary, or thyroid gland dysfunction. Common findings are that of low T3, T4, and TSH. It is reversible after recovery from the illness or surgery. It is partly caused by cytokines or other inflammatory mediators acting at the hypothalamus, pituitary, thyroid gland, as well as on hepatic deiodinase system. Degree of abnormality correlates with the disease severity. Administration of thyroid hormones in this situation is controversial and has not been shown to improve outcomes. Now, for the treatment of hypothyroidism, oral replacements with L-thyroxine is done. It is started with 50 to 100 micrograms. In elderlies or in patients with coexisting ischemic heart diseases, it is started at a lower dose of 25 microgram. It is further titrated by clinical improvement and by serial monitoring of TSH levels. T4 has a half-life of 7 days and its onset of action is 12 hours and it takes almost 2 weeks for its peak action. Whereas T3 has a shorter half-life of 1.5 days and hence it is available in injectable forms to be used during emergency cases. Hypothyroidism after Graves' disease needs replacement of 75 to 125 micrograms per day. Now moving on to the anesthetic management of hypothyroidism, in history taking, we have to look for clinical signs and symptoms of hypothyroidism as has been covered in the previous slides. If there is a thyroid swelling associated, we should ask for onset of the swelling, duration of growth of the swelling, rate of growth, as well as whether there is pain associated with it or not. As Hashimoto's thyroiditis is usually associated with pain, and if there is a hemorrhage within the swelling, there can be pain associated. Pressure symptoms have to be ruled out like dysphagia, stridor, hoarseness of voice due to recurrent laryngeal nerve compression. Dyspnea may be present due to pleural effusion. In past history, it is important to ask for any previous course of treatment and whether it had any effect on the swelling growth or not. We need to ask for radiotherapy exposure to the neck in the past history. In family history, it is important as some cases of endemic goiter are prevalent in families and certain enzyme deficiency disorders also have a genetic predisposition. In personal history, dietary history of food goitrogens is important. In drug history, we should ask for drugs like amiodarone and lithium which lead to hypothyroidism. Now going for the physical examination, general survey of the patient needs to be done. Build and state of nutrition should be asked as these patients are obese and have an edematous kind of look. We should look for mask-like faces, periorbital puffiness, mental status and intelligence need to be documented. In vitals, we need to look for bradycardia while measuring the pulse, and these patients are usually hypotensive. In skin, we should look for non-pitting edema. Local examination and all, I won't go into details as this has already been covered by Dr. Shilpa. Now moving on to the investigations relevant to the hypothyroid patient. In general, complete blood count, we should look for hemoglobin as there is anemia associated. In coagulation profile, it is important to look for BTCT, PT-INR as there is mild platelet dysfunction associated with factor 8 deficiency, which can lead to APTT disorder. Renal function tests need to be assessed as there is decreased GFR. Blood sugar levels should be monitored. Electrolyte levels to rule out hyponatremia. Lipid profile is important as there can be increased cholesterol, triglycerides, CPK and LDH levels. In ECG, low voltage QRS complexes, sinus bradycardia, flattened or inverted T waves may be seen. In chest X-ray, we have to look for cardiomegaly due to pericardial effusion. Sometimes pleural effusion may also be present. X-ray epilateral view to check for tracheal deviation should be done. Indirect laryngoscopy by ENT surgeons preoperatively to check for vocal cord movements is necessary, and we should screen for other autoimmune associated disorders. Thyroid specific investigations are free T3, T4 and TSH levels. Single best predictor at cellular level is TSH levels. Thyroid scanning for cold hypofunctioning nodule should be done. Thyroid ultrasound to look for cystic, solid or mixed lesions. CT MRI can be done to look for tracheal compression or mediastinal involvement. TPO antibody screening can be done in cases of Hashimoto thyroiditis. Now, in subclinical hypothyroidism, TSH levels are in the range of 5 to 10 milli-international units per liter, and T3, T4 are normal. While in frank hypothyroidism, TSH levels are more than 20, and T3, T4 levels are both decreased. Now, pre-op optimization. Choice of the patient is important. Mild to moderate hypothyroidism, there is no need to postpone elective surgeries. But in severe hypothyroidism or pregnant patients and patients with myxedema coma, we should postpone the surgery till patients are euthyroid. Surgical stress may precipitate myxedema, coma, or thyroid storm in untreated or severe cases. If patients have to be taken in emergency, then it should only be done after consultation with endocrinologist. What are the anesthetic consideration in a hypothyroid patient? They have increased risk due to airway compromise because there is swollen oral cavity, edematous vocal cords due to deposition of glycosaminoglycans. There may be goitrous enlargement compromising the airway. Delayed gastric emptying may be present, which may lead to risk of aspiration and regurgitation. Hypodynamic cardiovascular system is present, as there is decreased cardiac output, impaired baroreceptor reflexes, as well as low intravascular volume. All of these conditions are further compromised by surgical stress and cardiac depressant anesthetic drugs. There can be decreased ventilatory response to hypoxia and hypercarbia, which is further enhanced by anesthetic agents. Hypothermia is very important as it can land up a hypothyroid patient into myxedema coma. Hematological abnormalities need to be taken into consideration, such as anemia and platelet dysfunction. Hyponatremia and hypoglycemia are also associated with these kind of patients. Now, the increased sensitivity of drugs is present because of reduced cardiac output and compromised cardiovascular system. There is also decreased hepatic metabolism and decreased renal excretion of the drugs. This all leads to increased circulation time of drugs. Hence, in such patients, while giving narcotics, we have to be very cautious, or we can even avoid preoperative sedation. There is negligible effect on MAC value, but they are sensitive to myocardial suppressant effects of volatile agents. So in pre-medication, NPO status is same, 6 hours for solid and 2 hours for clear fluids. Informed consent should be taken from patients. No preoperative sedation or minimal preoperative sedation can be given, as it leads to respiratory depression. Adequate IV fluid loading preoperatively is needed, as they tolerate hypovolemia poorly. Anti-aspiration prophylaxis and antibiotic prophylaxis as per hospital protocol should be given. Continuation of thyroid hormones on the day of surgery is crucial. Hydrocortisone 100 mg IV should be given, as there is usually associated adrenocortical insufficiency. Induction of drugs, while giving all anesthetic drugs, they should be given slowly and in titrated doses. Ketamine and etomidate can be given as agent of choice, as other drugs usually are associated with hypotension. Reduced doses of neuromuscular blocking agents are used, as there is muscular weakness already present. Rapid sequence induction with scoline is preferred for difficult airway. And if you're anticipating a airway obstruction, you can even go for awake fiber optic intubation. You can ask attendant to lift the gland upward and laterally till the tip of your endotracheal tube goes beyond the area of tracheal compression. Armored flexometallic tubes are better to avoid kinking under the drapes, and they should be firmly taped, and all those connections should be secured, as access during the surgery is limited, as we have a shared airway with the surgeon. While maintenance of anesthesia, it is usually done with oxygen, nitrous, and iso or sevoflurane, as it provides a balanced anesthesia. Fentanyl should be given in titrated doses. Vecuronium is used as it is intermediate acting. Pancuronium has risk of prolonged action and residual neuromuscular blockade. Hence, though it has an increased sympathetic activity, it is usually avoided. Hypertension is to be managed by dopamine, ephedrine, epinephrine, not by any pure alpha agonist, as there is down regulation of alpha receptors. Hence, phenylephrine is not effective. Controlled ventilation is preferred if you are using LMS for certain hypothyroid cases. It is always preferable to go for controlled ventilation, as there are chances of hypoventilation in case of spontaneous breathing. IV fluid of choice is DNS, as it avoids both hypoglycemia and hyponatremia. In intraoperative monitoring, basic monitors like pulse oximetry, NIBP, and ECGs should be attached to check for MI or any arrhythmias intraoperatively. We attach ETCO2 probes. Urine output monitoring is done. Temperature probe is very important here as they tend to land into hypothermia. Neuromuscular monitoring is done as there is interference with excitability in hypothyroid patients. ABG and blood sugar should be regularly monitored. If a major surgery is expected and you are expecting a large fluid shift, CVP line, intraarterial blood pressure monitoring, pulmonary artery catheter, and transesophageal echo can be done to check for intravascular volume. Active warming of patients in this case is important, which can be done by providing warm IV fluids, blankets, and by keeping the ambient temperature of OT warm. In extubation, if these patients are posted for non-thyroid surgery, full awake extubation can be done in semi-recumbent position. In thyroid surgery, usually deeper planes at extubation are preferred as it avoids risk of cuffing and wound hematoma. Direct laryngoscopy and visualization of vocal cords post-extubation should be done to rule out recurrent laryngeal nerve injury. In cases of suspected tracheomalacia, fiber optic bronchoscope should be used. And if there is a with cuff-leak test, and if you are suspecting and seeing a tracheomalacia, then you should keep the patient ventilated. In emergency surgery, it is ideal to postpone it for at least 24 to 48 hours as L-triiodothyronine has its peak action between 24 to 38 hours. So at least postpone it for that time duration. Meanwhile, you can start the patient on L-triiodothyronine 25 to 50 microgram IV initial dose, which can be followed further by IV T3 of 25 microgram 8 hourly. L-thyroxine of 300 to 500 microgram IV can be given over 1 to 5 minutes. Rapid T3 is not given as it can lead the patient to land up into angina. Hydrocortisone or dexamethasone can be given due to decreased adrenal function, and phosphodiesterase inhibitor, milrinone, is used for treating reduced myocardial contractibility. Now, what are the risks that are involved in emergency surgeries? There is increased risk of cardiovascular instability intraoperatively, and patient can have myxedema coma post-operatively as they are not optimized. Now, in the post-operative period, we have to, the patient may need post-operative ventilatory support because of delayed emergence. Post-op analgesia, such as wound infiltration, regional techniques, small doses of opioid or ketorolac can be used. IV hydrocortisone 100 mg 6 hourly can be given. We should check for calcium levels 6 hourly and 24 hourly, as sometimes accidental parathyroid hormone excision with thyroid gland may occur. We have to check for hematoma formation, and if drug can't be administered enterally after 5 days also, IV levothyroxine can be given as 60 to 80% of the oral dose. Now, what are the complications associated? There can be myxedema coma, delayed recovery owing to hypothermia, muscular weakness, slow drug biotransformation, and low basal metabolic rate. Respiratory depression or failure may be present. Obstructive sleep apnea may be there. Hyponatremia, hypothermia, hypoglycemia, prolonged post-operative ileus or bleeding may occur. Now, the most important complication, last but not the least, most important topic is myxedema coma. In this, there is severe hypothyroidism resulting in a decompensated metabolic state, and the cardinal feature of which is mental status change. It is usually seen in elderly female over 60 years of age. They have symptoms of thinning of hair, loss of eyebrow hairs, alopecia, puffiness of face, bagginess under the eye, enlarged thyroid gland, myxedematous thick non-pitting skin. Severe bradycardia is present with severe hypotension. Poor appetite is there. Patient may have constipation. There may be cool, clammy extremities with swelling of the limbs. Carpal tunnel syndrome may also be present. Patient may have infertility or heavy menstruation, and patient is usually hypothermic. So the precipitating state for this is infection, cold exposure. Infections such as urosepsis, pneumonia can lead to this state. Cold exposure or hypothermia is the most common cause leading to myxedema, coma, stroke, or myocardial infarctions. Medicine intakes such as amiodarone or lithium can lead to this state. In laboratory findings, we will see hypoglycemia, hyponatremia, hypoxemia, and hypercapnia may be seen on ABG. Prolonged QT intervals with low voltage QRS complexes are visible. Pericardial effusion may be seen. Management of this condition is basically supportive, and patient usually revert back within few days. So management is for hypothyroidism. Initial large IV doses of 300 to 500 microgram are given of T4. If there is no response, then we can add triiodothyronine, or alternatively, initial large IV dose of 200 to 300 microgram of thyroxine can be given with 10 to 25 micrograms of T3. Hypocortisolemia may be present, in which IV hydrocortisone is for which hydrocort is given 200 to 400 mg daily. If hypoventilation is present, we should not delay intubation and mechanical ventilation for too long, as it can lead to, as they have already suppressed reflex, to hypercapnia. Hypothermia if present, then just warm blankets are sufficient. No active remodeling is needed. For hyponatremia, mild fluid restriction is sufficient, as it is basically mostly dilutional hyponatremia. Hypotension, for that we can give cautious volume expansion with crystalloids or whole blood. For hypoglycemia, glucose administration in the form of D24 or D50 can be given. And whatever the precipitating event is, identification of that and elimination by specific treatment is crucial. Liberal use of antibiotics is recommended. Sometimes they are associated with severe lactic acidosis, for which 8.5% of soda bicarb can be given. So that is the end of my presentation. Thank you, everyone. Thank you so much.
Very good discussion by our Poonam. There are few questions in chat box. One is for Dr. Shilpa. Which is the reliable marker for thyroid function, T3, T4 or TSH?
TSH is the most reliable marker as it is the most sensitive of all of them. And though for subclinical cases of hypo or hyperthyroidism, free T4 needs to be checked and to diagnose if it's a subclinical hypo or hyperthyroid.
I think you have to also go for the signs and symptoms. If the patient is having goiter or thyroid swelling, then you must look for the signs symptoms as described earlier by you. And I think the total plasma thyroxine level, T4 level, is most also reliable for screening the thyroid gland function. So that you have to also look into. So I think all the T3, T4, TSH, both should be looked into when you are doing the thyroid function, looking for the thyroid disease.
Yes, ma'am.
Hello?
Yes,
There is
ma'am.
one more question.
Yes,
Management of acute bilateral recurrent laryngeal nerve palsy in the immediate post-operative period. How will you manage?
Yes, in immediate post-op, if a patient presents with stridor, respiratory distress, or aphonia, the laryngeal nerve palsy should be suspected. It's a life-threatening situation, and immediate action needs to be taken in the form of emergency intubation or tracheostomy needs to be done.
Yes, that is why we, when we are examining the patient in preoperative assessment, we must always look for the indirect laryngoscopy. Why it is necessary? Because we must know the whether the bilateral vocal cord movements is whether normal or there is any abnormal bilateral vocal cord movements. Many times during the dissection, they can damage the recurrent nerve, laryngeal nerve. So basically the bilateral recurrent laryngeal nerve damage is very rare. Most commonly, they might be a unilateral recurrent laryngeal nerve palsy. So we have to look after the extubation. We must show the vocal cord movement to the surgeons, and also it should be noted on paper also medico-legally. And also the hoarseness of voice can be also noted if it is there in preoperatively or also in the post-operative period. So basically, I must say that for the postgraduate students, they must know the proper nerve supply of the larynx as well as the thyroid gland. So basically, how the motor supply of the thyroid gland takes place with the and also the sensory supply. So I will just elaborate in few this thing. That superior laryngeal nerve is mainly the motor supply which supply the upper part of the vocal cord, sensory part. And it is mainly the motor supply to the cricothyroid muscle. And the recurrent laryngeal nerve is the main motor supply, except the cricothyroid, which is supplied by the superior laryngeal nerve. So, and the recurrent laryngeal nerve supplies the sensory part below vocal cord. So we have to look into the, after the surgery, the vocal cord movements are important.
Madam, one more question is there. For thyrotoxicosis, only beta blockers or plus other antihypertensives?
Usually in thyrotoxicosis, the hypertension, it can be managed with beta blockers that it controls the heart rate, and if required, calcium channel blockers or ARBs can also be used for better control.
What drug you will prefer?
For beta blockers, it's propranolol, the most preferred drug, as it helps in peripheral, inhibits the peripheral conversion of T4 to T3. And in calcium channel blockers, verapamil can also be used, or in ARBs, I guess the sartans, the telmisartan.
Hello. Hello.
Yes, madam.
There are one more question. Euthyroid state in hypothyroidism should be rely on clinical parameters or TSH value. Dr. Poonam?
Yes, ma'am. Basically, euthyroid state in hypothyroidism should be relied on by TSH values, as nowadays there are very sensitive TSH assays which shows the euthyroid state in hypothyroid patient, and we can also judge by the improvement in the clinical symptoms after taking the treatment. So that is also seen, but TSH should be relied upon.
Okay, there is one more question for you. Importance of reverse T3.
Basically, reverse T3 is formed by metabolism of T4. So it is T4 metabolism when it gets converted to T3 and reverse T3. It has no other importance as such, except it is seen in sick euthyroid syndrome. And values of reverse T3 are 14 to 30 nanogram per deciliter. So if some patient is showing signs of depression and all, then usually with T4, values of reverse T3 is ordered by doctor. But independently, it has as such no significance.
Okay, there are no, I think no any other questions in the chat box. Anybody wants to have any questions? Hello?
Madam, if there are no questions, we can conclude. If there are no questions, with your permission, we can conclude then.
Sir, I will just wanted to add one thing.
Yeah, you can say, madam.
Yeah.
You are the
Sir, generally in final year MD exams, the postgraduate students are mainly they prepare only for the hyperthyroid and thyrotoxicosis, and the hypothyroid topic is mostly neglected.
Yes.
And when we turn into the hypothyroid, when we ask them any question regarding management of hypothyroidism or anything, then they just get fumbled. So I think it's a very good topic which you have given us, both hyperthyroidism with atrial fibrillation and hypothyroidism. So it's a very nice presentation by our own team. Thank you so much, sir, for giving us again the opportunity in this academic webinar. And we will look into more and more this thing. We will like to take part in more and more webinar like this. Thank you very much, sir.
Thank you very much, madam. The reason I have stressed on myxedema is, as a postgraduate, MD postgraduate, my first symposium topic was hypothyroidism and its anesthetic management. Coming for incidental surgery. Still, I remember every word because I have rehearsed it 6 times before presenting. Now it helps, and I thank you very much. It is a phenomenal presentation at the chairmanship of Dr. Chaya Suryavamsi madam, the evergreen. I thank personally Chaya madam and the team, Dr. Shilpa madam, Dr. Poonam Kannurkar, Dr. Dheeraj Kumar, everyone, and they are living up to the expectation of D.Y. Patil Medical College. Really, these people are an asset to the established medical college. So over to Dr. Suresh Kumar sir, our president.
Thank you, sir.
Thank you, Stelam sir. A wonderful session. We have covered all the aspects of thyroid diseases, hypo, hyper, and storm. On behalf of ISA Pudukkottai, I thank our chairperson for our excellent navigation of the session and useful inputs. I thank all the speakers. We are at the end of the session. Now I welcome our treasurer, Dr. David, to deliver the vote of thanks. Over to Dr. David.
Sir. Good evening to all. On behalf of ISA Pudukkottai, first I would like to thank our academic chairman, Dr. J.L.M. sir, for continuous webinar on 29th webinar. Thank you, sir. Special thanks to today's chairperson, Dr. Chaya Suryavamsi ma'am, professor and HOD of Dr. D.Y. Patil Medical College, Pimpri, Pune, for sharing your wonderful experiences. Thank you very much, ma'am. And also thank today's speakers, Dr. Poonam Kannurkar and Dr. Shilpa Deshmukh and Dr. Dheeraj Gopal Ravindran, sir, for excellent academic session. And also thank other faculties and postgraduates and Akirala and A1 Logics for technical support. Thank you very much. Thank you all.
Thank you, sir.
A1 Logics.
Thank you all, madam.
Shilpa, we close the session.
Thank you.
சிம்மாஃபில் கொடுத்து வரல. என்ன கொடுத்தாங்க அப்போ? வச்சுக்கோங்க, எழுதிக்கிறா வச்சுக்கோங்க. இல்லைன்னா சிம்மாக்கு வாங்க எடிமான். இப்போ எல்லாமே போட்டீங்க.